Welcome everybody to the distal radius fracture section 1. We have a busy session and hopefully we'll have a fruitful session. So we're just about on time, so if we'll just ask the speakers to keep on time, will be very much appreciated. And we will get started with our first speaker of flexor pollicis longus tendon rupture after volar plate fixation of the distal radius fracture from Daiki Yamamoto from Japan.
Please.
Yeah, we'll move on to the next paper. Complication after distal radius fracture stabilized by volar blocking plates in 392 patients. Distal radius fractures by Maridia Victoria Sales from Guatemala.
Good day. And complication in patients with fracture of the distal radius. My financial disclosure statement. Aims. Identify complications that occur in patients with distal radius fractures, DRF, during the first follow-up year. Identify the incidence of complication in DRF. Methods. This is a cross-sectional study. Sample size were 745 subjects, both genders, adults, more 18 years old, underwent treatment only by hand surgeons, time period January 1st, 2010 to December 31st, 2015. My methods: medical chart was reviewed, a telephone survey was conducted, X-rays were analyzed by the principal investigator, a study was approved by hospital IRB. My results: age between 18 and 95 years old. 25% were from 51 to 60 years old. Total fractures, 758. The most affected side was left in 53%, bilateral fractures 1%. The majority of our patients perform low demand activities and were either housewives or retired in 41%. The mechanism of the injury in 459 fractures was low energy, being the most frequent falls in 61%. In our hospital report, 17% of complication in patients with distal radius fractures. 5% of the complications require surgical treatment. In our study, we describe fractures according to the classification AO. The most frequent type was A3 with 30%. Type of treatment: 69% of the patients required surgical treatment. In 6 years, the DRF frequency was on the rise, but the complications have remained stable. Our complication was 129 patients, and tendons 26%, nerves 18%, scar 11%, carpal tunnel syndrome 6%, complex regional pain syndrome 5%. Conclusions: The majority of complications are associated with tendons and nerves. All tendon ruptures occur in patients older than 50 years old. Most complications occur in patients older than 50 years, and most complications occur in female patients. Thank you.
Hello. Question for you? Okay. A question? Yeah. Okay. This was a telephone survey.
Yeah.
Do you think you underestimate the number of problems, or do you think you have an accurate estimation of the number of problems?
In a survey, no problems.
Okay. Okay, thank you very much.
Now, complications after distal radius fracture stabilized by volar locking plate in 392 patients from Stefan Guadelbauer, Austria. From the same hospital I was 4 years. So, Stefan, tell us something.
Ladies and gentlemen, dear Chairman, I'm pleased to speak about our complications after operatively treated distal radius fractures in 392 patients. We have no conflict of interest, and as we also know, distal radius fractures are common and are the most common fractures in the upper extremity, and until 2030 will have an increase up to 50% of incidence in distal radius fractures due to an increased life expectancy. Additionally, in the last years, palmar locking plate fixation of distal radius fractures become the standard treatment of distal radius fractures. The first reports of Orbe in 2002 and 2004 were very promising with 3 to 4%, and he reported a good functional outcome. But in the last years, more studies had been published, and the complication rate was reported here up to 39% after operatively treated distal radius fractures. Aim of our study was to investigate the complication rate and the functional outcome after volar locking plate fixation, and to compare the complication rate in patients over and under 65 years of age. The inclusion criteria were older than 18 years, an isolated acute distal radius fracture, and had to be treated by open reduction and palmar plate fixation. The follow-up interval had to be with a minimum of 3 months. The exclusion criteria were open fractures, polytrauma, and the follow-up interval shorter than 3 months. We treated from 2013 to 2016 over 1,000 distal radius fractures. From these 253 had to be excluded, and another 400 because of a follow-up shorter than 3 months. So the final analysis comprised 392 patients. When we now look at our results, we had a mean follow-up of 11 months and a mean age of 57 years. The most common type of fracture had been type C fractures with 67%, and patients under 65 years of age were more common with 73%. When we now look at our complications, you see that 68 patients out of 392 had complications, a complication of about 70%. The most common here were CRPS, CTS, screw loosening, and intra-articular screw placement and tendon irritation. But when we analyze our results more in detail, you see that only 6% of the complications are directly related to the implant. When we now compare the rate of complications in age, gender, and type of immobilization, so a cast or a splint, you see here that there were no differences in occurring complications between the groups. When we now look at the radiological results in patients under and over 65 years of age, you see that we found no differences in palmar tilt and radial inclination, and as well for loss of reduction, no significant differences could be found. When we compare the functional results on the left side, on the right side, you see patients over and under 65 years of age. There were no differences between these groups. But when we compare patients with complications to those with no complications, you see that they had an impaired range of motion in all planes except for supination and radial deviation. When we now look at this case example, this 65-year-old woman with this distal radius fracture was stabilized on the day of the injury with an wall locking plate, as you can see here on the right X-rays. 1 week after surgery, there was loss of reduction from the dorsal fragment and subluxation of the lunate dorsally and intra-articular scoop protuning. So after wound healing, we performed a revision surgery and additionally stabilized the distal radius fracture from dorsally, as you can see here in this X-rays. Here the functional results 4 months after injury, the patient regained a good range of motion and the fracture healed in anatomical position. What can we now say in summary? Distal radius fractures are common and will get more common in the next years. And the first rates of complication were low to 3 to 4%, but the average in the literature given is up to 16%. When we look at the literature, the most common complications are carpal tunnel syndrome, tendon irritation or rupture, and CRPS. From our study, we can conclude that wall locking plate fixation is safe and results in the majority of the cases to a good functional and radiological outcome. But we had a complication rate up to 70% with a mean follow-up of 11 months. The most common complications in our study was CRPS, carpal tunnel syndrome, and loss of reduction. And we saw that patients over 65 years of age had no increased risk for complications or decrease in range of motion, and gender and type of immobilization showed no impact on the complication rate. And patients with complications had a significant decrease in range of motion than patients without complications. Thank you.
Thank you, Stefan. How could we avoid these complications? Loss of reduction, CRPS?
CRPS, it's not, in our opinion, it's not influenceable by the surgeon. It occurs also in normal distal radius fractures and is not contributed to the fracture itself.
Then loss of
reduction. To avoid fixature externe is one possibility to decrease CRPS.
We have seen a case where you went in from the volar side. It was a dorsal key fragment. I think we should analyze the fractures and go in for the key fragments to avoid secondary dislocation. That's true?
Yes.
Okay, thank you.
Thank you.
Okay, so our next paper is anteromedial release for post-traumatic flexion pronator contracture of the wrist by Inma de la Belancasa from Spain.
So a question, anteromedial, is that the common terminal in your country? Anteromedial release. As you know, in hand surgery, we don't say anteromedial, that means volar ulnar, yes. That's true?
Yes.
Yeah.
Yes. Sorry. Good morning. My name is Inma Puig de la Bellacasa. I come from Barcelona, and I'm going to talk about wrist stiffness and this volar release that we propose for treating flexion pronation contractures of the wrist. I have no disclosures, and this is the patient we meet. We can see that he's a young patient with no arthritis, no bone injury to his joint, but he can't supinate nor supinate neither radial deviate his wrist. I've divided the talk in these 5 blocks. So our purpose was to propose you a novel technique, surgical technique, that has been developed by our group to treat patients with wrist stiffness due to a soft tissue contracture in flexion pronation. This is to solve, to improve in the range of motion, not denervating, neither in destabilizing the joint. Thank you, Mark, to share this project with me. Most of the pictures you'll see are from his own. So the pathoanatomy of the disorder has a lot to do with the mechanism of injury. And this is the typical fall in an outstretched hand with an injury to the ulnar side of the joint. The patient, there is a shear mechanism of traction to the distal radioulnar joint. There's a traction to the mid-carpal ligaments, an impaction to the pisotriquetral joint, and also a traction to the tendon, the FCU tendon, or either to the myotendinous union. If the injury goes ahead, we can have also a pronator quadratus disruption. And in the meantime, we can find this girl that has a completely lack in supination and radial deviation, so she can do the dart throwing motion, the radial component of the dart throwing motion. Of course, when, as we see yesterday in the instructional course, when we have a loss on pronosupination, the first that comes to our minds is a bony affection. No? If we have a distal radius malalignment, a radioulnar discrepancy, or a joint incongruity, this is the first cause of losing pronosupination, and we'll have to treat it. But today we are I want to talk to you about this special soft tissue contracture that really is very uncommon. The etiology is still unknown, but we think that there is something that provokes an excessive fibrotic response during the reparative process. This causes at first pain and a lot of disability. It can be either intraarticular or extraarticular, and the conservative treatment has failed. So when considering surgical management, Lee and colleagues described a very useful classification considering the location and the functional limitation that provokes. And they classified into the wrist stiffness in intrinsic type 1 and extrinsic type 2. Considering the intrinsic ones, the ones that are intraarticular, so adhesions, locking, or bone incongruity, some cause that is provoking inside the joint, while the extrinsic causes are provoked by capsular retraction, capsular thickening, muscle retraction, or wherever is outside the joint. Depending on the location, we can find it dorsally, palmarly, to distal radioulnar joint, or a combination of all of them. That makes it easier to find, to guess which one is the best treatment, because the intrinsic ones are best afford arthroscopically, although it's a quite high demanding surgery, as said Lucchetti by yesterday, and the extrinsic ones are going to be treated open. So once we've classified the extrinsic cause of the stiffness, we're going to avoid it by the ulnar side when the problem started. And our landmarks of the incision are going to be the pisiform and the volar border of the ulna. We make a Brunner incision and we raise the flaps. And the first we are going to meet is the dorsal sensory branch of the ulnar nerve that is going to be retracted and protected. The FCU might be also retracted, and we can do a step cut longitudinal incision to put in the length, when we reconstruct it, put the length that is better. And the pisotriquetral joint is going to be approached by its medial side. So we longitudinally dissect the extensor retinaculum by its medial side. Proximal to the TFCC and in the deep exposure, we can see the pronator quadratus and the volar capsule of the distal radioulnar joint. If we find it retracted, we can open and release it from the ulna, the pronator, and the capsular will do a capsulectomy, many years described by Clayman. We have to take care not to disinsert the volar radioulnar ligament on this ulnar side. And distal to the TFCC, we can raise the pisiform to radial and approach to the triquetruamate and triquetrucapitate ligament and dissect them. We have to be sure that we achieve the radial side and we dissect until the space of Poirier. This is a specimen. So we've made 8 patients. This is an example of a woman, 52 years old, with a minimal radius distal fracture that had pain at the beginning and a lot of rigid stiffness, also in supination and pronation. And this is another patient that had this same problem, but without any bone affection. After a long time of 6 months of rehabilitation, she could move, like as you see. So the conclusions are that we describe this new approach to approach the volar corner of the wrist. It is a safe, reliable, and reproducible technique to solve the extrinsic stiffness of the wrist when the conservative treatment has failed and when we don't have any bony affection. And it restores not only the supination, but also the basic dart thrower motion. If you have any questions, I'll be glad to answer.
Thank you very much. Any questions from the floor? Wolfgang?
A nice procedure, which we also do, because in supination, the head of the ulna has to translate to the vulnar side, and if there is a scar, it does not work. And if you resect or if you open up, then it is working again. Thank you for your explanation.
Thank you.
Okay. Our next paper is Post-Traumatic Deformities Around the Wrist, 2-Stage Treatment, from Alexander Zolotov from Russia.
Dear colleagues, at first, I declare no potential conflict of interest and no financial support. The treatment of bone and joint deformities is a challenge for surgeons. Correction of all deformities is connected with the risk of damage of peripheral nerves and blood vessels, and therefore, in case of severe deformity, 2-stage treatment with slow distraction using external fixator at the first stage can be an available alternative to acute deformities elimination. It's logically, according to Elizarov research and the Elizarov phenomena, slow distraction stimulates bone and soft tissue growth. And we use this principle for the 2-stage treatment of neglect phalanx dislocation, or for 2-stage treatment of the severe form of Dupuytren's contracture. And now I would like to present our experience of using the same 2-stage treatment principle for correction of post-traumatic deformities around wrist. We analyze the treatment of patients after distal radius fracture, 4 cases, perilunate dislocation, 3 cases, and perilunate fracture dislocation, 3 cases. Period of time following after trauma varied from 1.5 months to 4 years. Elizarov apparatus was used at the H state in all cases. 2 K-wires were inserted at the level of the forearm, and 2 K-wires at the level of the metacarpal. In some cases, we used the additional K-wires inserted through the distal radius metaepiphysis. Normally, we use the handmade traction with tower for assembling of Elizarov apparatus. And this device, made from improvised means, details from standard Elizarov set. Furthermore, this device can be used for the wrist joint arthroscopy. And our wrist tower is cheaper compared to brand devices. The rate of distraction was 1 millimeter per day. Distraction period continued for 3 to 4 weeks. Surgical procedure at the second stage included open reduction and bone internal fixation bone grafting of radius, open reduction of perilunate dislocation, and screw fixation and bone grafting of scaphoid non-union. In all cases, severe deformities were corrected with the aid of distraction. Slow distraction provided a gradual lengthening of soft tissue, and previous stage 1 surgical procedure facilitated the performing of stage 2. Bone deformities were eliminated in all cases, and bone healing was achieved. Perilunate dislocations were reduced in all cases. Function was improved in 9 cases and recovered fully in 1 case. There was a complication after synthesis, wires broken and loosening. Some clinical cases: male, 32 years old, distal radius fracture malunion, 2 years after trauma, osteotomy and slow distraction at the first stage, open reduction, internal fixation, bone grafting at the second stage. 1 year after second stage, bone healing in a good position and good function. Male, 42 years old, distal radius and ulnar fracture non-union, 2 years after trauma. Slow distraction at the first stage, open reduction, internal fixation, bone grafting at the second stage. The X-ray, 1.5 years after second stage, unfortunately, wires broken and loosened. Concerning the delayed and chronic perilunate dislocations, nowadays there is no agreement regarding the time limit for open reduction after date of trauma, and recommendations from different surgeons are varied enough: 2 months, 3 months, 4.5 months, about 9 months, and our patients repeated this ladder of time. 5 weeks after trauma, perilunate dislocations, radiostelloid fracture, at the first stage slow distraction, at the second stage open reduction, internal fixation. 1 year after surgery, no pain, strong wrist, almost full range of motion. 4 months after trauma, perilunate dislocation, scaphoid fracture, non-union, at the first stage slow distraction, at the second stage open reduction, internal fixation, bone grafting. 1 year after surgery, no pain, good function. 8 months after trauma, perilunate dislocation, scaphoid fracture, distal radius fracture. At the first stage, slow distraction. At the second stage, open reduction, internal fixation, bone grafting. 5 years after second stage, stiff but strong wrist, minor pain after heavy work. Thus, two-stage treatment of severe post-traumatic deformities around wrist is effective and safe, and pre-distraction at the first stage makes it easier to do the second stage surgical procedure. Thank you very much for your attention.
Thank you. It's a very elegant way to deal with a difficult problem. Would these, over what time period did you gather these cases up?
Maybe during 5 years.
Over 5 years. So it's not a common thing, but you'd have a large referral practice. You have patients coming from a long way.
From another hospital.
From other hospitals. Okay. Good. Okay.
I think distraction is a very good method also in finger contractures. So I have not seen it in wrists, but it seems to work.
Maybe.
Yeah. Thank you. Next lecture, zone criterion, the risk of flexor tendon rupture, post-volar plate application, what is associated risk of the loss of the normal volar tilt. Jesse Jupiter, United States.
Thank you. These are my disclosures. We wanted to look at the predicting value of the Soon criteria, but most additive to this is whether or not the loss of volar tilt puts the patient as well at greater risk of tendon problems. To do this, we've looked at almost over 200 cases from our ICUC database, which is available to all the cases via the ICUC app. No charge for any of this. And we looked at, and as we've heard, it's not a totally common problem, but one that perhaps needs further insight into identifying the etiology as well as treatment. We know this, and we've heard this throughout the meeting about this seminal paper regarding the SUN criteria. One of the things we don't hear so much is which point on the volar distal radius do you use for your measurements? Because the volar radial point is a little bit more prominent than the ulnar point, so it may make a little bit of a difference in measuring the SUN criteria. Well, let's look at a few of these cases to get a better idea. And this patient ruptured at 29 weeks, a 60-year-old woman. If we look at the CT scan and X-ray pre-op in your upper left corner, and then the surgical treatment, and if you look sequentially at 14 weeks, 26 weeks, and then 29 weeks, you get a sense that maybe there's a little bit of more prominence in the volar plate, as well as perhaps a little bit loss of volar tilt that we had at the time of initial surgery. And this would be certainly a dangerous position, and the flexor pollicis longus ruptured. This next patient, and this is also important in that this woman ruptured at 80 weeks. And the point is that follow-up of 1 year may not be sufficient in eliminating the possibility of flexor tendon rupture. The CT scan is seen in your upper left, and then the initial treatment. This is at 80 weeks after the plate was removed. But if we follow sequentially at 26 weeks, 79 weeks, and then 80 weeks at the time of rupture, we do see as well a little bit loss of the original volar tilt, and the SUN criteria becomes a little bit more demonstrable. And the last patient is a partial rupture, patient presenting with pain, difficulty moving his thumb. Here's your 3D CT and regular CT, and sequential X-rays we'll see, and at 40 weeks, a very prominent volar plate. Fortunately, the patient came in before total rupture, but you can sense that there's a little bit of a loss of volar tilt as well, and we found a partial rupture. And so I think this brings up some interesting points to consider. Should we really try to get the best fixation, perhaps putting the plate a little bit more distal, or work on this with more proximal placement and a safer position? Should we remove these plates? At 20 weeks, a distal radius fracture is probably healed, and maybe protruding plates should be removed even if non-symptomatic. What if we should do with younger patients with the idea that there is a possibility that flexor tendon rupture may occur at a much later date? When we use this, which volar point on the very distal radius do we use? Is CT perhaps more precise than conventional lateral X-ray to determine the exact nature of the plate prominence? And how important is the volar tilt or loss thereof in the genesis of these ruptures? Those are the questions to consider. Thank you very much.
Jesse, thank you for your explanation. Well, maybe one solution would be to use other plates with other designs, maybe. As you know, we invented one plate called FPL plate with an incision between two columns to make low pressure on the tendons that you can mount also very wide distally. But anyway, we have to take care when we see when there's pain, we have to remove them. You agree with me?
Yes, I think the thing we've learned, and I think most people recognize now, that the rupture of a flexor pulse longus is very difficult, especially for a younger person, and prophylactic plate removal, especially if they're having some symptoms. The problem about plates, however, is economics. As we go further along with the economic issues, we don't always have many choices. And sometimes their institutions will purchase one implant that gives them the best price. So we have to be careful.
Thank you very much.
Thank you. So we're going along nicely. We're a little ahead of time, but our next paper is Comparison of Hand Function in Colles and Scaphoid Cast using a technologically updated Jebsen Hand Function Test from the United Kingdom.
So good morning, ladies and gentlemen. Thank you for giving me the opportunity to present my work today, a comparison of hand function in Colles and scaphoid casts using a technologically updated Jebsen hand function test. I have no disclosures to declare. Scaphoid fractures are common fractures. They account for 90% of carpal bone fractures. These can be treated surgically or non-surgically with cast immobilization in a Colles cast or a scaphoid cast, which is otherwise known as a thumb spiker cast, for a period of 6 to 8 weeks. But there has been ongoing debate for decades in regards to thumb immobilization in the treatment of these fractures. In recent times, there has been widespread use of technology. In the UK, in 2018, 82% of adults owned at least one connected device, and 95% of those aged 16 to 24 owned smartphones. Worldwide, a person, on average, spends greater than 2 hours on social media each day. We can therefore more or less say that the use of computers and mobile phones can be considered part of our modern-day ADLs, activities of daily living. So the purpose of our study was to compare hand function in a scaphoid and Colles cast using a Jebsen hand function test. This was developed in 1969, consists of 7 subtests as shown in the table on your left, and these tests reflect the activities of daily living. In our study, we included 4 additional subtests, which reflect the use of mobile phones, computer mouse, and a computer keyboard. We used 20 healthy volunteers with a mean age of 28 years. All subtests were performed using the dominant hand in no immobilization in a Colles cast and in a scaphoid cast. All subtests were performed 3 times each, and the order of test conditions for each participant was randomized. Apart from the typing subtest, which was measured in words per minute, all subtests were measured in seconds. And paired t-test was used for statistical analysis. I will not be going into the details of the original Jebsen hand function test, as the tests were performed as per protocol. But I will briefly talk about how we assessed hand function using computers and mobile phones. So texting on a mobile phone, the participant held the phone in both hands, predictive text and autocorrect functions were disabled. Participants were given a card with a written phrase, and the time taken to text the phrase correctly was measured. 3 different phrases were used, as shown. Using a computer mouse to point and drag a target. This was created on PowerPoint. Participants were instructed to use the mouse to point and click on target 1, which is the blue box, and drag it into target 2, which is the red box. Time taken to complete the entire screen was measured. Using a computer mouse to scroll. Participants were instructed to scroll to page 150 on an ebook, and time taken to scroll to the correct page and stop was measured. And finally, typing on a computer keyboard. This test used a free online typing website, which tracked participant performance by calculating the words per minute. This test was repeated 3 times using pros of equivalent complexity. So the results of our study. The graph on your right shows the average time taken to complete each subtest. The average was based on 3 attempts. The y-axis is time in seconds, and the x-axis is the subtest. The blue line represents no cast, red is Colles cast, and green is scaphoid cast. From this graph, you can see that any immobilization, whether in a scaphoid or Colles cast, prolonged task completion times for all subtests. You can also see that the average time taken to complete subtests was greater in a scaphoid cast in comparison to a Colles cast. The table at the bottom of the screen is the summary of the results of the typing subtest, which shows that the average number of words typed per minute in a scaphoid cast was 42, in a Colles cast was 45, and without immobilization was 53. So what tests reached statistical significance? We had 5 subtests which reached statistical significance, and these are as follows. These subtests involve fine motor skills coupled with rotational movement. So, from our study, you can see that cast immobilization impairs hand function, and scaphoid casts further restrict hand function when performing modern tasks such as typing and texting. Literature as far back as 1991 suggests that thumb immobilization does not enhance scaphoid union. So I ask you, should we still be immobilizing the thumb in the modern era? So to conclude, inclusion of the thumb in our study in a cast impaired fine motor skills assessed by the Jepson hand function test. Scaphoid casts further reduced the ability to use modern technology, but when we compared it with the Colles cast, statistical significance was not reached. But I think it's important to carefully consider the need for immobilization of the thumb for treating scaphoid fractures, because it can affect hand function when performing both traditional and modern-day ADLs. Thank you. Any questions?
Thank you very much. Nicely done paper. What I'm going to say to you is, can this be used for getting people back to work? Or do you use it in that kind of situation, whether someone's fit to go back to work in a cast?
So I think with our study and the 20 sample size of healthy volunteers, I don't think we've answered that question. It doesn't confirm it because it doesn't take into account variables such as pain, person's stamina. So I think it's, this is the basis of a pilot study, and we could potentially in the future consider a larger cohort and assess, taking into account those variables.
You know, we are coming from a school of Lorenz Böhler, and he already described 1934 that there is no need for including the thumb into a cast. Until now, it's always the same, people include the thumb, but for what? Yeah, so let out your thumb of the cast. The most important thing is that you include your volar side and dorsal side, that the people can't go out of the cast, but the thumb does not matter if it's out or in. Thank you.
Yes, I completely agree. Thank you.
Thank you very much.
Again, Stefan Guarlbauer from the Lorenz Böhler Hospital in Vienna. Active wrist mobilization after operatively treated distal radius fractures by volar locking plate, a prospective randomized trial.
Ladies and gentlemen, I'm pleased to speak about our results in active wrist mobilization without immobilization after distal radius fractures. We have no conflict. And one of the advantages of the volar plating is that it enables, in the biomechanical study, an early mobilization of the wrist and provides enough stability to let the patient without cast, and thereby a faster rehabilitation and shorter sick leave can be enabled and supposed in the literature. But when we look at the literature, we have only a few studies available, especially prospective randomized trials that compared an early mobilization with an immobilization after distal radius fractures. So the aim of this study was to investigate an early postoperative mobilization if it leads to a better clinical outcome than immobilization by cast for 5 weeks. We included 116 patients with an age under 75 years. The inclusion criteria had been age between 18 and 75 years. We included A2 to C3 distal radius fractures, and there had not to be any acute or older injury that influences the hand function. The exclusion criteria were an age over 75 years, type C 3.3 distal radius fractures, and patients unable to give the informed consent. We performed an blocked enveloped randomization in 2 groups. The first group was the intervention group. This group got a removable cast, as Tevenplast explained, for 1 week, and got active physiotherapy from the first day after surgery. The control group was the cast group, which had a non-removable cast for 5 weeks and thereafter started with active therapy of the wrist. The examination points were 6 weeks, 9 weeks, 3 months, 6 months, and 1 year after surgery. We performed an X-ray in 2 planes of the wrist, documented the range of motion, pain, grip strength, and all patients got the DASH score, PAVE score, and Meyer wrist score. When we now look at our results, we had the majority of the patients were women with 73%, but we had a shorter duration of sick leave and duration of physiotherapy in the early mobilization group, but no differences in rate of complication and no significant loss of reduction between the groups. When we now look at our functional data, you see here in extension and flexion, we had significant better results in the early mobilization group up to 1 year, in supination and pronation up to 9 weeks, and in radial and ulnar deviation as well up to 9 weeks. When we look at grip strength and pain, you see that as well for grip strength we had significant better results up to 1 year for the early mobilization group, but there was no significant difference in pain between the groups in the whole study interval. When we now look at the scores, we had a significant better DASH score up to 3 months after surgery and a significant better PAVE score up to 9 weeks after surgery. The Meyer wrist score showed up to 1 year significant better results in the early mobilization group. Here one example, this 29-year-old woman with this distal type C radius fracture was stabilized by a locking plate and wrist mobilization was started at the first day after surgery. Here the results 6 weeks after surgery with a nearly complete free range of motion and no loss of reduction in the X-rays, as you can see here on the right side. So what can we know in summary? Early mobilization after distal radius fractures stabilized by a locking plate leads to a significant better functional outcome than immobilization until 9 weeks in all scores and range of motion. We had a significant better Meyer score and range of motion extension and flexion and grip strength until 1 year, and we found no significant differences in pain between the groups according to visual look scale. We had a significant shorter duration of sick leave and physiotherapy, and just the same, an early mobilization didn't lead in a higher rate of complications, and we had no significant risk for loss of reduction between the groups. Thank you.
Thank you very much.
Well, that's an interesting thing, because we know that in a lot of radius fractures we have accessory lesions like SL lesions or TFCC lesions, and without any immobilization, that doesn't matter. And the second question is, if you have a lady, 70 years old, and you did your operation, and you found out that it is not very stable with your screws and plates, also in these cases, you let them totally free.
Yes. Because according to study protocol, we don't know it. Because the loosening of the screws only knows the surgeon, and the study team is blinded to this.
Are there questions from the audience? Are all letting the wrist free after plating? Who puts on a cast? Hands up. A lot, a lot. So you will change your mind after that paper or not? Are you afraid to change your mind? Okay, thank you very much.
Okay, you're a very quiet audience, and I would encourage you to ask questions in the future. Our next paper is worst outcome DASH at 12 months in 128 patients with combined radius ulnar metaphyseal fracture and radius fracture alone. Registered at 3,666 patients. From Linnea Ardvison from Sweden.
Yes, thank you very much. Good morning, and thank you for this opportunity to present. In our department in Lund, in Sweden, we treat approximately 450 adult patients with distal radius fractures each year. Since 2002, we measure outcome by DASH at 3 and 12 months, and we include this data in our register. Dr. Landgren showed in his thesis in 2017 that most of our patients return to pre-fracture state and have a DASH value of between 0 and 10 at 1 year. 1/3 have moderate symptoms still, and 17 report the major symptoms with a DASH value of more than 35, which can indicate, for instance, pain at rest. By working with our register, we have been able to identify subgroups with inferior DASH values, where an intervention possibly would have a large impact. One of these groups are the patients with distal radius fracture in the combination of a distal concomitant metaphyseal ulnar fracture. So all the styloid fractures, only ulnar styloid fractures are excluded. In this patient group, we found that after 1 year, they have a worse DASH value with a value of mean 23 compared to 9 for the whole cohort. And here you see the combined fractures to the right and all the patients to the left. And as you see, there's room for improvement. Only 1/3 return to pre-fracture state with minor symptoms at 1 year. 37% report moderate symptoms, and 1/3 have major symptoms after 1 year with a DASH value of more than 35. This is the group of patients we looked further into. Up to 6% of all patients with a distal radius fracture have a concomitant distal metaphyseal ulnar fracture. Treatment algorithms are widely used for distal radius fractures, but to our knowledge, there is none for the concomitant distal ulnar fractures, and the ulnar fractures are actually rarely mentioned. We used our register to identify the patients with both a distal radius fracture and a distal ulnar fracture. All the x-rays were reviewed, and the fractures were classified according to the AOQ modifier and the Bionic classification system for distal ulnar fractures. Patient characteristics and patient-reported outcome was extracted from the register. And as I said before, all the Q1, the only styloid fractures, were excluded. For each of the patients with a distal radius and ulnar fracture, age and gender matched control with a similar fracture date, but only distal radius fracture were selected from the register. The medical records were reviewed for the type of treatment, use of medical drugs, and comorbidity. During this time period, 127 patients were included with a combined fracture. We saw that the patients with combined fractures were significantly older, with a mean of 71 years compared to 62 for the whole cohort. About half of the surgical treated patients had fixation of both radius and ulna. So we treated half of the patients surgically, and half of them had fixation of both radius and ulna. The non-surgical patients had a below elbow cast, non-circulated in most cases. We couldn't see any difference in DASH between the surgically treated and non-surgically treated patients. Various surgical methods were used for the fixation of ulna. Both of the groups had high rates of comorbidity and polypharmacy. About 70% in both groups had at least 1 point in Charlson index score for comorbidity, and about 20% met the criteria for polypharmacy by taking more than 5 different medical drugs daily. We couldn't see any significant differences between the groups, except that the combined fracture group had a significantly higher intake of oral steroids and osteoporosis treatment. So here you can see that the scores for comorbidity and use of drugs were about the same in both groups, except for steroids and osteoporosis treatment. Previous studies have shown that a higher age correlates to an inferior DASH value, but we couldn't see this in our cohort. The only correlation to DASH we found was polypharmacy. The patients that were taking more drugs tended to have a higher DASH value at 1 year. By using our register, we have been able to find this subgroup of patients with both a distal radius fracture and a concomitant distal metaphyseal ulnar fracture. They have a clinically relevant worse outcome by DASH with 23 in median compared to 9. Additional studies are needed in the future to determine how to best treat this patient group in aim to improve their outcome. Thank you.
So you've identified a group of patients that have a difficult outcome. You found nothing in the treatment options that made a difference?
No, we couldn't see any difference regarding the treatment, no. But this is a small cohort, so maybe we can if we have more patients. But it's quite rare with those fractures, so we need to have more patients included.
So we just need to warn these patients when we see them that they're going to have a more difficult outcome. Is that your conclusion?
My conclusion is that we need to do further studies and maybe aim to do a randomized trial with either surgical treatment or conservative treatment. And maybe since our treatment in this cohort is very diverse, maybe we need to discuss how to do it and then compare the different methods.
Well, also we were looking for this concomitant ulnar lesions, and also we used different methods, and this is really hard to get these fractures fixed in a proper way. There are no recommendations in the literature too, and now there are some plates on the market which should be working. What we do is that we put a plate on it and one axial K-wire, and that seems for us to be the solution to get no fracture on the plates or something else. So I think we should also work on the method how to treat distal ulna, not only radius plates.
Exactly.
Thank you.
Thank you.
Thank you very much.
So now our next lecture, association between radiological results and functional long-term 6.8 years outcome in conservatively treated AO type C distal radius fracture from Leena Raudasoja, Finland.
Greetings from Helsinki, Finland. Dear Mr. Chairman, dear audience, we have here the results of a group of distal radius fractures treated conservatively in Helsinki University Hospital. A long-term follow-up. Aim of the study was to find out if the from beginning achieved position of fracture will remain in cast immobilization. And is there any association in between radiological findings and clinical outcome of these potentially unstable type of fractures? It's a retrospective study. As we can see, we can achieve maybe a proper position of the fracture with cast immobilization, though even in our hospital we operate on 1,350 patients wrists yearly, but not all of the fractures. We collected a consecutive group of patients who had AO type C fracture in their wrists. We called them to a follow-up about 6.8 years after fracture. 41 of these 63 patients came. 2 of them had to be excluded because they were operated elsewhere. Mean age of the patients was almost 60 years. The outcome analysis was made with standard X-rays, clinical examination, and with quick DAS and PRWE patient-rated wrist evaluation scores. Statistical analysis was made with Mann-Whitney U analysis. Here we have the demographic data of patients. Results of these C-type relatively unstable wrists majority of the wrists had a deterioration of the primary alignment. Even if in the beginning, all wrists, the primary reduction result was acceptable according to the national current care guidelines. And even in 24 wrists, the final alignment did not remain in the limits of these accepted guidelines, even if in the beginning they were. Radius shortening compared to ulna, 2 millimeters or more, was found in 19 wrists, and dorsal tilt of radius 10 degrees or more in 12 wrists. Step off on radius was just in 3 wrists in the beginning of treatment. After reduction, it was in 7, but there was some kind of remodelation during the treatment. Now, how did these aberrations affect the clinical outcome? Radius shortening compared to acceptable, this under 2 millimeters. Quick dash 10.9 versus 4.9, it was not significant. Dorsal tilt of radius compared to acceptable, quick dash 11.4 versus 6.6, they were not significant. As well, it was similar with PRWE. Radius shortening, if compared to acceptable, was 7.3 versus 4.8, and dorsal tilt 6.8 versus 5.6. Table of these associations, those 3 step-offs were not analyzed. But in case of any deterioration in exact radiologically anatomical result, with no radiological deformity, that we had only 7 who were in exact position, then there was difference in PRWE. But however, the result did not reach minimal clinically important difference. Conclusions. Majority of the AO type C distal radius fractures lost their initially achieved reduction during conservative treatment. But the association of distal radius deformity, at least when it is relatively mild, to poor clinical result is far from clear. Significant association solely between either radial shortening, dorsal tilt of radius, or step off on the joint surface could not be found to clinical outcome. Thank you for your attention.
Thank you very much.
Are there any questions from the audience? What do you recommend us? Not to operate radius fracture because it doesn't matter?
At least this, because we have these Finnish current care guidelines, and according to them, we treat the patients. And if in the beginning we get a proper position, so we do not operate. But it is sure, as I could see in this study, that most of the fractures, they get about back to the position.
Yeah, we know that the conservatively treated fractures all or mostly go to the previous position before a position. So the next question is, should we even reduce them? Because they go back to the position where they have in the beginning.
Yes, but I think that our study even shows that even if you, with operation, you get nice X-rays, and nice position, and position stays, that it does not lose the reduction, but does it really mean for the clinical outcome?
So if you had a radius fracture, you showed us picture with really deteriorated radial inclination and dorsal angulation. If you had such a fracture, would you like to have 1, no reduction, 2, reduction and cast, 3, operation with a plate?
If it should be in my left hand, I think that I should have a reduction and cast.
It's it's always the same, yes? So we have a lot of papers where the outcome is just the same, and when we ask the actors, then they say they wanted operation. Does not make sense. Anyway, make your own mind. Thank you for...
Thanks.
Thank you very much. Our next paper is a systematic review of the quality of distal radius systematic reviews, methodology and reporting assessment, from Vincentius Morales from Brazil.
Hi, good morning. Thanks for your time. And I'm here to present one systematic review of the quality of distal radius systematic reviews. I'm trying to say about methodological and reporting assessment. We know that distal radius fracture is a topic of prolific research, and in the 20 last years, various treatment options were tested, from randomized trials, which is the best evidence, to prospective series and also retrospective series. We know that when we look at the literature, there be like a significant number of systematic reviews that were conducted with the aim of summarizing to pool the results to result in better confidence. However, what we see today, that there is a really industry of systematic reviews, and this fact may lead these systematic reviews may lack of scientific rigor. They can be somewhat misleading and they can over or underestimate the real evidence, generating conflicting results. So we made a hypothesis that part of these systematic reviews from distal radius fractures, basically for treatment, they may lack of quality and may be the reason for the conflicting results on the subject. So the methods of the systematic review were registered a priori in the Prospero database, that is a United Kingdom database on the topic, and was registered in 2017. So all the following steps of the systematic review were performed in duplicate and in an independent form. We made a Medline research from the inception to May 2017. We restricted search for English-only papers, and we looked for distal radial fractures terms, and we performed also a filter for systematic reviews as it is available in the PubMed. So we included any kind of systematic reviews that dealt with treatment, that included any kind of study types, RCTs and non-RCTs, and that deal with distal radius fracture treatment, operative treatment, and also non-operative treatment. However, we just included the adult population, not the children. We have excluded when we found that there was no systematic review, it was a narrative review, and when the systematic review dealt with other kinds of outcomes, different than treatment, someone that dealt with risk and also with diagnosis. So we gather all this data, we get data from declared conflict of interest, research origin, types of treatment included, number of pooled patients, the citation of the PRISM statement, and the types of the study designs included. So we use it to measure the methodological quality, the Amster tool. We have a maximum of 11 points, and it encompasses search strategy, characteristics, internal validity, and the presence or the absence of conflict of interest. We also assessed the reporting quality by the PRISM statement that has 27 years that we have to answer yes or no for all of the questions. All the PRISM and Amster scores were done in duplicate to assess agreement. So we made also some subgroup analysis by impact factor, the presence or the absence of meta-analysis, if the study included only RCTs or included other kind of studies, and if the authors declared or not conflict of interest. So we made that analysis for means, and also we assessed agreement by experience correlation. And so we started with 186 papers, and we included in the final analysis 41. These are the reasonings of excluding some studies in the final stage. And we had like poor responses for Amster, with encompassed 59%, with a substantial inter-observer agreement. We also had poor responses to PRISM scores, however, with a better inter-observer agreement. And when we compared systematic reviews that only included RCTs versus all other study designs, we demonstrated Amster scores and PRISM scores were better in a significant way. It also happened when the systematic review included meta-analysis. As I can say, they have pooled the results. The scores were significant for PRISMA and also for Amster scores. However, declared conflict of interest and also journal impact factor seems not to be to worry about the results and the confidence of the systematic reviews. So we can conclude that distal radius systematic reviews may suffer from low methodological standards, and they be more reliable if they present RCT only as the inclusion criteria, if they can include meta-analysis, and if the authors declares that they have a conflict of interest. The journal impact factors seems not to influence in the quality of the systematic review. Thank you.
Thank you very much. So you're watching the watchers now. So do you think these scores, are these internationally accepted scores, and did you make any of these scores yourselves?
Yes, this is something difficult, but when you look in the literature, there are lots of scores that makes the same job. Mm-hmm. However, I think that Amster is a good one. Mm-hmm. I'm not sure if PRISMA has been developed for that. However, we implemented as another tool to measure. Mm-hmm.
Okay. Any questions from the floor? Okay.
Thank you.
Thank you very much. Okay, so next paper is pain as a main predictor of the one-year outcome of distal radius fractures, from Magnus Tagel from Sweden.
Thanks a lot. Mr. Chairman, ladies and gentlemen, this is another paper from the Lund Distal Radius Fracture Register, presented by Linnea previously. So we treat our 450 adult patients for distal radius fracture each year, and all patients 18 years and older are registered prospectively and consecutively. And we send them this DASH inquiry, 3 and 12 months post-fracture, and DASH is a PROM, a patient-reported outcome measurement tool, evaluating the subjective outcome of the patient. And the result, as Linnea was presenting, basically 50% return to a pre-fracture status with a DASH between 0 and 10. 1/3 have moderate symptoms with DASH between 10 and 35, and 1/6 between 15 and 20% have an inferior result with severe symptoms, including pain at rest after 1 year. So the idea with this study was to find early predictors of that inferior outcome and see if we could proactively prevent complications early on before they become manifest. So in addition to the DASH, which we send out at 3 and 12 months, we also send to the patients in working age 18 to 65 years a yellow flags inquiry at 2 weeks after the fracture. And yellow flags, that's a term taken from the car racing industry, basically warning signs, watch out, troubles ahead. So we register general health like age, sex, BMI, smoking and comorbidity, which we know is important. Socioeconomic data like educational level, ethnicity, and what kind of work the patients have. We're interested in previous pain experience because sometimes people have a fracture after having a low back pain for 5 to 10 years. So we were interested in a coping mechanism and the previous sick leave. We're also interested in present fracture, how they perceive the present fracture, like intensity of pain, stress, and tendencies to catastrophic thinking. So we did a correlation between the answers of all the questions compiled at 2 weeks to the outcome after 12 months. And you can see a good correlation was found between the 2 weeks and the 1 year. We did a linear model to identify the yellow flag questions, which of the yellow flag questions was the most important predictor of the 1 year outcome. And we found that 30% of the outcome at 1 year could be explained by the predictors. And self-evaluated pain during the first 2 weeks by far was the best predictor. You can see almost 40% of the 1 year outcome was due to the perceived pain at fracture time or the 2 weeks after that. Comorbidity, education level, and coping somewhat important too. So to conclude, the level of pain experienced by the patients the first weeks after the fracture seems to be the most important factor to predict a high QuickDAX score at 1 year. And in the next step, the results of this study will be used for early interventions in patients with high initial pain levels. Thank you.
I think this pain issue that we get with immediately after Colles fracture is very important. We struggle sometimes with patients who have pain in the first few weeks to get ahead of it. And despite splitting a cast, doing pain relief, are there any other factors besides this acute pain that can help us predict or strategies that can get ahead of that problem?
Yeah, but this is perceived pain, so it's not an absolute pain or the worst fractures or anything. It's the patient's own view of pain. So it includes their personality, it includes catastrophic thinking. Yeah. So the message here is these are all our 4,000 patients undergoing our standard treatment. So maybe we should pick some of those who we don't understand. Why are you complaining so much? And they should have not the standard treatment, but go into another rehab track maybe.
And did you see if any of this group went on to develop CRPS?
Yeah, we have very, very little CRPS measured at 1 year, but these are only inquiry-based studies, right? Yeah. So these are only the inquiries.
Any questions there?
That yellow flag question, was that something that your centre developed itself?
We had that from our pain anesthesiologists. So it's a tool they use for their chronic pain patients. Yeah. So it's published papers, and when it came some 15 years ago, that was meant to be the solution of everything. Was not. But we use it for this purpose.
Thank you very much.
Next topic, outcomes of supplemental bridge plate fixation of highly comminuted distal radius fracture treated by open reduction internal fixation, Libby Anderson, New Zealand.
I'm actually from Brisbane, Australia, but this comes out of some of my work while I was a fellow in Auckland, New Zealand. Thank you for the opportunity, Mr. Chairman and audience. I have nothing to declare. The background is that we know that highly comminuted intra-articular distal radius fractures are a unique challenge, and this work comes from a high-volume unit in Auckland. And I'm looking at the outcomes of our supplemental dorsal bridge plating for distal radius open reduction internal fixations. Our indication for bridge plate supplemental fixation is a complex polyarticular unstable fracture pattern with a high chance of collapse, and we feel that the dorsal bridge plate or supplemental fixation facilitates mid-carpal control and restores lateral carpal alignment. We're aiming for restoration of the articular surface and radiological parameters throughout, and we see that this plate is simply a neutralisation device. On review of our cases, 5 senior hand surgeons in a single tertiary unit between the 1st of January 2016 and end of December 17 operated in total on 283 distal radius open reduction and internal fixations, and only 10 cases also required a neutralisation device, so this is less than 0.04%. Of these 10 patients, 2 were male and 8 were female, and they had a mean age of 61 years. All fractures were in AO classification 23C3. The mean date of injury to surgery was 9 days, and the mean date of surgery to removal of the supplemental bridge plate was 74 days, and we had a mean follow-up of 16 months. This is a table showing the various techniques, and as you can see, all fractures required some form of fixation in order to anatomically reduce the articular surface, and many required bone graft. 8 patients had their bridge plate to the 3rd metacarpal and 2 to the 2nd, and that was surgeon preference with an intraoperative decision made at the time. With regards to radial inclination, we had a mean inclination of 21 degrees, and that did not change from screening to last follow-up. With regards to volar tilt, we had a mean of 4 degrees, and 2 patients did lose some volar tilt at their last radiological follow-up. And with regards to ulnar variance, we had a mean of -1 millimetre, and 4 patients did lose some ulnar variance looking at their last radiological follow-up. Interestingly, this same group of surgeons have an unpublished group looking at 131 distal radius open reduction internal fixations, and I was able to age and gender match the 10 patients from our bridge plate fixation to a control group, and I was able to look at the 12-month follow-up of both groups. Unsurprisingly, this control group had somewhat less complex fractures because they didn't go on to supplemental bridge plate fixation. Looking at our objective outcomes with the operative wrist, these were our range of motion scores and a grip strengths. When measuring this to the uninjured wrist of the patient on the opposite side, we had significant differences in flexion, extension, and ulnar deviation, and this is not entirely surprising given the extent of the fracture and the bridge plate fixation. But when we look at the control group, so those that had distal radius fixation without supplemental bridge plate, the only significant difference was grip strength, and all range of motions were relatively similar. Just briefly, finger stiffness, some patients did, but the majority could achieve a tip to distal palmar crease distance of 0 centimetres. Of note, both patients 8 and 10 had bridge plate fixation to their 2nd metacarpal, and anecdotally, both of those patients commented to me on follow-up that they noticed index finger stiffness, which they thought had been slower to overcome. With regards to subjective outcomes, I apologise, we looked at PRWHE and quick dash, and unsurprisingly there was significant differences between the operative wrist and the control group, but these may reflect the complexity of the injury associated with those that required bridge plate fixation. I looked back at the literature, and this paper from Lauder et al. Looked at 18 patients, but this was using dorsal distraction plating only, and our group had a superior range of motion. This group from Richard et al. Was a retrospective review of 33 patients. Again, the plate was used as a distraction device. However, 7 patients did require supplemental KY fixation. Our radiographic outcomes were similar, but our range of motion outcomes were slightly better. In this paper, there was a note of finger stiffness, and it was thought that that could be over-distraction, and one patient did require an extensor tenolysis, and another patient had CRPS. This is a paper from Hand and Microsurgery that probably is the one paper in literature where there was more of an attempt to reduce the articular surface and then put a distraction plate on. Again, our range of motion results were slightly improved, but certainly we had a better grip strength in this group, and our patient-reported outcome scores were slightly better. In conclusion, we believe that there is a narrow indication for using a dorsal bridge plate, but most importantly, anatomical reduction of the joint should still be achieved, and we see the bridge plate as a neutralisation device. We've had no cases of CRPS, and this is heavily reported in the literature as a complication of these plates, but this is when the plate is used more as a distraction device. Our objective outcomes are comparable to distal radius ORIFs without bridge plates. Our subjective outcomes are worse, but this may be an indication of a more severe injury. Our results were superior to those in the current literature, and I believe that this is the first study that reports on the outcomes of the neutralisation bridge plate as a supplement to truly anatomical fixation with otherwise standard distal radius fixation techniques, and it compares a bridge plate series to a case-matched control group. Thank you.
So, yeah, these are difficult cases. my own personal experience has been the stiffness with these afterwards. You seem to have got very good results. Any tricks or tips to tell us you got pretty good range of motion on them, you know?
I think, I mean, like we had a decent follow-up, so we had a mean follow-up of 16 months. And I think inherently we all just, you know, certainly early on in my training, I felt like this bridge plate was sort of the work of the devil. I was going to commit these patients to having a terribly stiff wrist. And simply we just haven't, there's just not much in the literature to show that that's what is occurring. And this is really something that shows that we're potentially not committing these people to a stiff wrist. And in fact, if you're fixing a fracture and intraoperatively and you've anatomically reduced the joint, you've put bone graft in, but you still have that feeling that this might collapse, then I think it's a small series, but it shows that, you know, it's probably the right thing is to put a neutralization device on in order to prevent collapse and therefore, you know, potentially get good range of motion outcomes as opposed to not.
Yeah. And what stage do you take the plate out at?
So the average was about, I'd have to go back, but we aim for about 3 months.
3 months.
It was a South Auckland demographic, so some a little bit longer.
Good. Any questions from the floor? Okay. Thank you very much.
Thank you very much.
Okay. Okay, our final paper is Do National Randomized Controlled Trials Change International Clinical Practice, from Rosie McColgan in Ireland from our unit. Thank you very much.
Good morning. I'm presenting the results of a study we did under the supervision of Mr. Sullivan in Galway. Many of you will be familiar with the draft study, which was published in the BMJ in 2014. It was a pragmatic randomized control trial comparing K-wire fixation to locking plate fixation in patients with dorsally displaced fractures of the distal radius. 461 patients in 18 trauma centres in England were included in the study. The authors concluded that there was no clinically relevant advantage between the two methods and therefore advocated K-wire fixation on the premise that it's cheaper and it's quicker to perform. It was subsequently shown that draft had an impact on clinical practice in the UK. There was a decrease in locking plate fixation from 75% before the study to 48% after, and there was an increase in K-wiring from 12% before the publication of draft to 42% after. The aim of our study was to examine trends in the management of distal radius fractures in Ireland and to examine whether the draft study resulted in any change in clinical practice in Ireland, and by extension, whether it changed international clinical practice. So we collected HYPE data over 10 years from January 2008 to December 2017, and HYPE is the principal source of data on discharges from acute hospitals in Ireland. So our results, we find that we perform nearly 2,500 procedures per year in Ireland for fractures of the distal radius. The mean age of our patients is 56. The female to male ratio is 4:1. And we find that in Ireland, we had a decrease in K-wiring from 59% in 2008 to 30% in 2017. And we had an increase in locking plate fixation from 21% before draft to 62% afterwards. This graph just illustrates our trends, and the red line illustrates the increase in volar locking plate fixation, and the blue line is K-wire fixation. While our trends are the opposite of those in the UK, they're the same as those in Europe. And these are our total annual procedures, and you can see that there's a higher number of procedures in 2010, which is when we had above average rates of SNO in Ireland. The training scheme in Ireland is almost identical to that in the UK, and we have the same exit examinations. There are 16 acute orthopaedic trauma hospitals in Ireland, and 13 of these have at least one specialist registrar in orthopaedics in the department. So the dotted lines are the non-training hospitals. The blue line are volar locking plates, and while plate fixation overtook K-wire fixation as the most popular treatment modality in training hospitals in 2013, K-wire fixation remains the most popular method in non-training hospitals. So why have we not followed the findings of draft? While it's one of the largest randomized controlled trials to date, it is a single study, and some smaller randomized controlled trials have shown an early benefit in locking plate fixation. We need to consider what makes studies internationally relevant. Ireland and the UK have similar patient demographics. While we don't have any guidelines providing a standard of care of orthopaedic trauma in Ireland, in the UK, both the NICE guidelines and the BOSE guidelines are prescriptive and have recently been updated to assimilate the draft findings. But guidelines can affect both surgeon and patient autonomy, and the patient as well as the surgeon may find that the early advantage of locking plate fixation is important. And there are differences in cost in volar locking plate fixation between countries. Draft is a pragmatic study, and pragmatic studies have been the focus of a number of recent editorials in the BJJ. And while draft as a pragmatic study would have provided an analysis of locking plate fixation compared to K-wire fixation across a range of surgeons and patients, it may not have provided the ideal environment that an explanatory randomized controlled trial would have. There are a number of limitations to our study. It's hype data. The codes weren't specific for dorsally displaced fractures and weren't specific for volar locking plates. A large proportion of the population would not have met the draft criteria, and we don't have the data on patients managed conservatively. So in conclusion, it would appear that surgeons in Ireland don't appear to be influenced by pragmatic randomized controlled trials performed in the UK. Thank you.
I'll let you ask the questions here.
Well, other questions from the audience?
There you go.
Well, we had different meanings in, yeah.
A very nice study. Just a question, it seemed that your study looked at figures between 2010 and 2017, and might it be that there's a bit of a lag effect, so with new evidence of anything, there's always a bit of a ripple effect, and maybe the ripples haven't quite got to Ireland yet. So it might be that it's changing as we speak now, and so would it be worth repeating the study in, I don't know, a year or so? And the other thing is, in terms of establishing figures, the usage of plates, had you considered or did you approach companies to see if they'd seen a change in the number of plates that they had sold?
So I think there was a study performed in the UK, and they saw a change as early as 2014. But our trends seem to be towards plates.
As Mr. Chairman said, there are different opinions. The draft study, those 400 patients were operated by 200 surgeons. So if you have a setting where you have a lot of surgeons doing very few fractures, you might be wiser to use K-wires. If you have another setting where you have more specialized surgeons, maybe it's better you can use advantages of more complicated surgery, more dangerous surgery. So maybe it's not bad that you don't listen to the English people, and because there are a lot of studies coming out now showing efficacy of the volar plating.
Yeah, we don't have any randomized controlled trials of our own from Ireland, so I suppose we'd advocate that, you know, maybe in future going forward we should have international collaboration on them, and then we might get.
Okay. Well, thank you very much, everybody. Everybody's kept ahead of time, and we have a little bit of extra time, so there'll be a break now before the next session.